comes about, and recognizing that there are societal expectations, but there are also biological underpinnings. The topic of gender identity, I guess, is really what is most at hand here, and this is what we refer to as a person's perception of being male or female. And again, from a scientific standpoint, we're going to point out some important features of that. We won't speak directly about sexual orientation, but it certainly is another component in this conversation. But I want to point out the way that words are used and understood has a profound implication for the care that we're going to be delivering to the people that come to us for assistance. I want to begin by just acknowledging some of the terms that are used, and from a biological standpoint, where one can question how this is being presented. And the first is that sex is a subjective condition, and that's reflected in the words that are often used, such that sex is assigned at birth based on external genitalia. It really is more accurate to say that we recognize the sex of an individual based on external genitalia. It is not something that we subjectively assign, with the exception perhaps of individuals that are born with abnormally formed genitalia. And now in the conversation, as we've learned more and more about the biology of sex, we recognize that our simple understanding of chromosomal sex, X and Y chromosomes, is really needs to be expanded. But in that expansion, there's been an attempt to segregate out chromosomal from genetic and hormonal and even phenotypic or neurologic sex. And we need to understand, again, coming back to the fundamental definition about what sex is, how these different components of sexuality really relate to how one participates in that biological process. Related to this, I think, is the claim that sex is not binary, but rather occurs along a spectrum. And we're going to talk about some of the biology related to that. And it's probably reflected in the desire to move away, at least in my profession, where we deal with individuals that are born with ambiguous genitalia, from recognizing this as being something that is not what is according to the way that human beings normally function, as a disorder, and really expressing this as a difference in sexual development, and being recognizing the sensitivity for people that are affected by this really need to be focused on what that really means as we try to help these individuals. And many times it goes as far as, because of these complexities, that there's a desire to ignore the biology, or say that it really does not matter. And there are individuals that will make statements that that gender is sex, that is what defines us because of that complexity. And we're going to look at in our time this morning how that actually plays out. And one way that people are trying to convey this complexity, and this is just one example, and I think many people really question the way this is presented. This is a way to look at the different aspects of human sexuality. And I think that part of the difficulty is when people are making claims that one, for example, doesn't have an anatomical sex, or they don't have male or female characteristics. We're going to, from a medical standpoint, we need to really recognize what the patients that we're serving as to the biology that's going on and how we can help them out. So just basic knowledge. We probably learned this in high school biology, that X and Y chromosomes determine whether we're male or female. As we've understood human sexuality at a deeper level, we recognize that it's not just the chromosomes themselves, but rather it's the genetic information that's present on those chromosomes that actually direct the formation of male and female sexual organs. And in particular, this is recognized that there's a genetic sequence known as the sex-determining region of the Y chromosome, or SRY, that actually directs a developmental process that allows an individual after the time of fertilization to develop into male or female. And I won't go into the details and the intricacy of the signaling processes that occur, but it is helpful to recognize that we're looking at genetic signals that are driving the differentiation of the developing embryo to be male or female. And this can be shown schematically as we have in any embryologic textbook, to look at the various structures that are pertinent to male or female anatomy. And again, I'm not going to go into detail with that, but I do need to mention this concept that sex occurs along a continuum. In the care of individuals that are born with ambiguous genitalia, and this is a diagram here known as a Prater scale that looks at infants that are born with various degrees of genital ambiguity. And that could be due to either over-virilization of females or under-virilization of males. And this is a reality. But how do we recognize this reality within the framework of understanding what sex is? And I think that it's very important to come back to that concept of the biological purpose of sex. When we look at this in the differentiation of into males and females, we know, and this is not controversial, that there are two and only two gonads, testes and ovaries, that participate in that biological process of reproduction. And therefore, there is no third gonad. There is no infinite number of gonads. And those that are affected by these disorders of sexual development, in general, are going to have impairment of their ability to participate in that reproductive process. Now, the difference between males and females is present throughout the body. So it is not specifically contained within the sexual organs, nor even the secondary sexual characteristics. Every nucleated cell in the body has this genetic information. And we can see this difference between males and females in many ways. One example, a very good example, is the concept of genetic imprinting. For example, the best example I can give is mutations in chromosome 15 that whether you inherit the genetic patterning from either the father or the mother, the same genetic mutation can lead to different diseases. For example, paternal imprinting leading to Prader-Willi syndrome, and the exact same defect leading to Angelman syndrome if inherited from the mother. And there are not only genetic but epigenetic changes that occur, and these are differences in the structure of the DNA that occur, DNA methylation and histone acetylation, that actually impact how genes are turned on or off that participate in the biological process. And this will be key in understanding in my second talk here, when we talk about some of the medical interventions that are proposed for people that are struggling with questions of their gender identity. So we can ask the question, why? This is a basic fundamental question in biology, that we reproduce sexually, and is put forward that this sexual a means of reproduction leads to genetic diversity through the process of meiotic recombination, and really directed toward the human person being able to respond, at least by some theories, to environmental stimuli that require us to adapt to various environments. Now, in the process of that's perhaps the why, but how? In order to be able to reproduce in the sexual way, members, male and female members of any species, need to come together. And so we need to think about this in terms of, from the biological standpoint, of the unitive and procreative dimensions of sexuality. So this relates to both how individuals come together, how they engage in sexual activity, and we can look very objectively at the design and function of the human body and very readily see the complementarity that one has between male and female forms that are specifically designed for participating in the reproductive process. Yet there is a social dimension to sexuality. Again, it does relate to how we meet and interact with members of the opposite sex, and how the expectations have been set up for us to act within society. And this is where, again, we're going to focus on biological aspects that much of the discussion is going on about societal expectations and gender of being a social construct. And I think it's important that if from a biological standpoint, that when we understand that the interaction that we're talking about here has a biological component, so that to be able to interact and carry out the roles not only of conceiving a child but raising that child to adulthood, and how the body is designed to be able to carry that out. And one of the ways that we look at gender, and again, to have a caution in over interpreting these stereotypes. So many of them are stereotypes. Some of them are biological underpinnings of what we would classify as feminine or masculine features, because we certainly know that some of the qualities of a human person that are listed, for example, in these boxes of feminine or masculine, are shared by both men and women. And so we really need to recognize that these may have features to how one participates in the raising of children, but it really is not intended to be rigid. But the mistake, and that should be recognized and accepted, but the mistake is then to say that this doesn't matter. Again, the point is that gender and sex are distinct components of our human sexuality, but they cannot be entirely segregated. Now, we do know that, for example, behavior is impacted quite significantly by the design of the human person and at the level of the brain, and very well known in many studies that have been published that there are clear sexual differences in brain structure between males and females, and differentially expressed genes that are impacted at the level of the genetics that I spoke to earlier, as far as imprinting and all of the epigenetic changes, but also can be impacted by environmental stimuli. And again, sorting these out can be very challenging as we look at the human brain and try to define a person by these brain structures is something that is not possible because of the diversity that occurs and the large overlap in these traits. So we're looking at population-based differences and features that are more predominant in males versus females. There's also a component of the sex hormones that are going to influence the function of the human body, in including areas of the brain, so that there are effects of sex steroids that will affect biologically how the brain functions, and certainly can have an impact on how one perceives their behavior. And to recognize that when we're talking about, we often think about estrogen and testosterone as the main sex hormones. There's several other steroid hormones that are present in the body, and there are certainly medical conditions that influence the levels of these hormones. Now, because of the importance of this whole reproductive process, there's an intricate signaling system that exists, beginning at the level of higher brain structures, including the pituitary gland, that signal to the respective gonads that a person has, testes or ovaries, to lead to downstream effects in production of the sex steroid hormones and their effects within the human body. So that we need to recognize this biological signaling pathway to understand fully what the impacts are going to be in altering these hormone levels in people that we are trying to help that are suffering from gender identity issues. Not only are the signaling pathways dependent upon which gonad is being stimulated, there are very key differences in the functioning of that axis from the pituitary gland to the gonad throughout life. And so when we intervene, or if we intervene to provide sex steroid hormones to an individual, whether that is happening at a time that is normal or abnormal, and this will be key when we talk about the question of pubertal blockade. I also want to point out, very importantly, how these steroid hormones work, these sex steroid hormones. So by the function of these hormones, estrogen or testosterone or any of the steroid hormones, they get into cells, they bind to a specific receptor, they get translocated into the nucleus of the cell where they turn on and off many genes. And the reason I show this slide is to highlight that the effects of the steroid hormones are not limited to the sexual organs. It's every cell in the body is going to be responding differentially to the effects of estrogen and testosterone. And it's going to be important as we talk about medical interventions, what the effects are of exposure to differing levels of estrogen and testosterone will be in the overall risk-benefit analysis as to how we proceed from the standpoint of a medical practitioner. A key point I also want to highlight to you is that both males and females have both estrogen and testosterone. However, the relative amounts of these hormones differ between males and females, and it also differs throughout the timing of life, so that during the prepubertal period, when that pituitary gonadal axis is shut off, levels of sex steroid hormone levels are very low. With the onset of puberty, we see a rise in a predominant rise in testosterone in males and a rise in estrogen in females. And again, how that impacts biology and overall health is going to be an important topic for us to consider. Not only that, adding another layer of complexity when we think about the ways that steroid hormones vary throughout not only the day and the month, we know very well the signaling that occurs during their normal menstrual cycle for a reproductively competent female, and in the way that we administer hormones as to whether that is going to truly recapitulate the normal biology that occurs. And this will be very important as we explore the effects of steroid hormones to individuals with a transgendered gendered identity in fertility. Not only are those variations present in females, it's often not recognized that males themselves have a diurnal variation, testosterone levels varying throughout the day, and then also throughout lifetime. And that much of the topic of conversation is in treating older adults, males with testosterone, reflecting the normal decline in testosterone over life and trying to reverse that effect that normally occurs. I won't spend an inordinate amount of time talking about the specific tissue responses to steroid hormones, the sex hormones, but just to highlight out the many different organ systems that are impacted and the respective role of estrogen versus testosterone. Key, there are clear effects of estrogen, for example, in the brain, in the heart, in the liver, in the bones, that we need to be aware of as we consider intervening in trying to alleviate suffering. And then the same thing we could say for testosterone. Again, very important effects, not only in the sexual organs, but also in bone, in the brain, and in muscle, and it relates to the physiologic differences that we see. And these are both hormonally driven, but also genetically driven as well. Next, I want to point out that there are many conditions in which there are abnormal genetic information. These can be single gene defects or whole chromosome differences. For example, the two examples of Klinefelter syndrome, where one has an X and a Y chromosome, but an extra X chromosome on top of that, or Turner syndrome, where one is missing an X chromosome. And again, pointing out that there are very clear physiologic differences related to these genetic abnormalities, and that invariably lead to impairment of fertility. Now, with that brief introduction, I'm now going to move on to talk about more directly about the individuals that have this gender identity, who they experience themselves as being male or female, that's discordant with their biological sex, and point out the vast majority of individuals that we're talking about here do not have one of the disorders of sexual development that I mentioned earlier. So prior to medical interventions, nearly all of the individuals we're talking about here have had normally formed and functioning primary and secondary sexual characteristics. Now, in any medical condition that we're talking about, it's important to have clear understanding of what is going on. And before I get into the medical interventions in the second talk, just to point out that there has been a shift, and many of you are aware of this, in recent years, to how we think about this as a medical condition, and many people that would want to argue that it is not a medical condition at all. Prior to the current edition of our Diagnostic and Statistical Manual, the DSM, for psychiatric conditions, this discordance between gender identity and biological sex was understood to be gender identity disorder, and it was understood that what is going on here has nothing to do with the physical body as far as the sexual phenotype, yet was something really specifically going on at the level of the brain and psychological understanding. And in the definition, I want to point out here again, getting back to what I mentioned earlier about the terms sex and gender, I think it is even reflected within the DSM itself. In that description of gender identity disorder, each of the different criteria was talking about the difference in persistence for cross-sex roles or cross-sex behaviors. When the newest edition of the DSM came out, by ideological reasons, not based on any new science. There was no science between DSM 4 and 5 that really drove the transition from gender identity disorder to the term gender dysphoria. What is intended in making that change is to accept in understanding that this discordance between biological sex and gender identity is not a problem. It is rather the discomfort that one has related to that discordance that is the problem. And many of the reasons for that is to be pursuing medical interventions. It's necessary to have something that you're treating. So if you make a statement that this discordance is part of the normal biological diversity of the human person, then it becomes problematic to explain why we need to intervene with powerful drugs and surgical interventions and something that is a normal variation. But I want to point out that in that change, the term gender began being used, pulling away from that biological understanding of what we mean by sex. So what is the prevalence of this condition? Again, in the DSM itself, these are the incidence rates, the prevalence that was reported as being a very, very rare condition, affecting a fraction of a percent in both males and females, a predominance really of biological males identifying as females. And really what the reason we're talking about this today is that in the last decade, there's been a dramatic increase in the number of individuals that are presenting with this biological sex gender identity discordance or with gender dysphoria. And one of the best data I think we have comes from the Tavistock Center in the UK. This is in the UK, all of the individuals that are seeking medical care for this condition go to the same facility, and it's been monitored over time, and we can just see the exponential increase in the number of people that are presenting for care. And it's often stated that the reason why this dramatic increase has occurred is that these individuals have always existed, and it is merely because of the availability of the facility that people are coming forward. And again, there's much that needs to be understood about other hypotheses as to why that is. Questions being asked about what's being discussed at the societal level is actually driving more individuals to have a transgendered identity that would otherwise attribute difficulties in development to other reasons. There's also been a dramatic shift in the number of biological females that are presenting as males. And again, that is the largest segment of the population that is increasing. And many questions that have remained unanswered as to why that is. There has been certainly some speculation about the societal role in that. And one of the ways that some of the necessary discussion at the level of science and medicine has been suppressed is merely to acknowledge the fact that this occurs. And many times adolescent females are presenting for the first time, not having had any evidence of gender identity issues in the prepubertal years, coming out in social networks. And again, the science here is very limited and really only hypothesis generating. And there's certainly much research that needs to be done. But many will remember the firestorm of press that came out when Lisa Lippman came out with this paper where she describes a condition as rapid onset gender dysphoria. To be able to understand and propose medical interventions that are going to be efficacious and really have benefit for the affected people that we encounter, it's often very helpful to know what the etiology is. And unfortunately, despite intensive effort and growing effort, the exact cause of gender discordance remains unknown. But there are some signals and some hints that we have, both genetically and environmentally, that help us to understand this condition. Before I get into some of the data, I would say that it's best really to say that from all that we know, that it is a multifactorial condition that includes both genetic and environmental influences, and really heterogeneous, meaning that the difference can be in any one individual. The contributing factors may differ in both nature and degree. I'll share with you just very, very briefly some of the papers that have been published trying to understand the etiologic basis for this gender identity question. And they look at both anatomic and functional differences at the level of the brain. For example, this is a paper from really 1995 looking at staining. This is from autopsy specimens and brain slices, looking at the base nucleus of the tractus solitarius, which is an area of the limbic system, and being able to see differences in people that identified with a transgendered identity from those that had a gender identity that was concordant with their biological sex. And some of the more recent tools that are being used as far as looking at functional connectivity and positron emission tomography and within the brain itself have gotten very sophisticated, and again, again, getting back to that slide I showed you earlier about the differences between the male and female brain, and some of the hints and observations of looking at people that have differences that correlate more with the biology of the opposite sex brain. The problem with this literature in all of the studies that we have right now is that there's a high degree of variability, very small sample sizes, and really unanswered are questions about how the environment and the social situation actually drives this process. So it's really a chicken or the egg question. We know very well that the brain has plasticity, meaning that the structural design of the brain can change over time in response to social stimuli. A further problem, and this is an important one here, that when we look at the differences between the male and female brain, there's so much overlap between the two that it is impossible to look at this functional or anatomical difference and be able to determine by that data alone whether one is male or female. We see this in other areas of human biology as well. It's well known that men, on average, are 5 inches taller than women. But it would be ridiculous for one to be able to say that I can determine whether one is male or female by measuring their height. And this is the curve that I show here on the left. On the right is actually looking at a quantification of that same area of the limbic system that I mentioned in that earlier study. And you can see that the overlap between these two conditions is quite substantial. And therefore, it provides perhaps some evidence that requires more investigation, but it is not sufficient for us to be able to make conclusions that there is a single biological cause. There's been many efforts to be able to assign a gene or several genes that dictate this condition. This is the same thing that has been attempted to be done in the area of same-sex attraction in a very well-known study that was published in one of the most prestigious journals in Science, Nature, really that concluded that there is no single gene that would drive that condition of same-sex attraction, and it's very likely that we're going to see the same thing in these gender identity issues, that there are multiple genetic loci that while they may exist, they are not determinative. So they may actually steer one to be more likely to have the condition versus not, just as we know for many other biological traits, such as, for example, alcoholism. One of the pieces of data, that looks at this is, twin studies, where you look at identical twins that have the same genetic information and look at the concordance. If one individual has gender dysphoria, the incidence of gender dysphoria in the other twin, as opposed to comparing that to fraternal twins that are non-identical in their genetic information. And really there is a higher incidence. That what can't be sorted out here, however, is the environmental influence, because the identical twins are being born to a similar situation. But they do provide evidence that there may be genetic contributors to this. It doesn't mean that it determines one's gender identity, and there could be many other explanations. For example, the genetic differences in one's resiliency, being able to handle various stressors, and many other hypotheses that could be made. There are many other hypotheses that have been proposed. And this includes differences in family dynamics, parental psychopathology. Very well understood, that there's a higher incidence, for example, of gender discordance, sex gender discordance in children with autism. The basis for that is still unknown. And again, we can look at the incidence of both psychological and sexual abuse in this patient population, and ask questions about whether it is cause or effect. Many people claim that the difficulties that one experiences is the result of that transgender identity versus that it was actually contributing to one identifying in that particular manner. So as I wrap up this first section of our discussion here, I want to return to this concept that we talked about as far as what sex is from a biological perspective. Again, that we need to be mindful of the reason why we exist as male and female for the biological purposes, recognizing that not every individual who is male or female will participate in that reproductive process or desires to do so in that way. Yet that is how the biology is designed, and what we'll explore in our next talk is going to be some of the implications of this underlying biology and how it needs to be included in our efforts to alleviate the real suffering that occurs in these individuals. And again, there are many resources that are out there. It's often confusing to be able to look through the literature in the detail to understand what's going on. There is a good report that was published in the New Atlantis on sexuality and gender. And I think it's a good resource for summarizing some of the information that I presented to you this morning. Again, I haven't directly addressed some of the statements that are made to challenge everything that I said. I think this is something that if we took all of the layers of emotion and ideology out of it is basic biology. This is something that we learn in medical school and even before that. It's very clear. Many people challenged this particular report, yet I have yet encountered anyone that has directly challenged the actual data. There was, a lot of uproar over saying we didn't like what this said, but what we really need to do is elevate the conversation to actually look at these basic fundamental biological aspects and be able to come to a better understanding of who we are as human persons. So with that, I'm going to wrap up and open this up for questions for our first session. I thank you for your attention for the beginning of our morning, and thank you very much.
Thank you, Dr. Roos. I think if you can reduce your screen from sharing your screen, we'll, there we go. We've had a number of questions asked during your first session, and the one that has received the most frequent requests has been asking for your comment on the impact of the Equality Act. I realize it's a very general question, but just some observations from your part on the possible implications of the Equality Act.
There are many aspects of the Equality Act, and I'll answer that question in relation to my role as a physician and as a physician scientist. That in areas of medicine, we focus on, we like to pride ourselves on evidence-based medicine. This is where, because of the conversation that is going on currently, the politicization of these medical practices have become to the point where it really presents many concerns for our ability to deliver the best medical care to these individuals. For example, aspects of the Equality Act that will mandate a physician to participate in the administration of these hormonal interventions without recognizing that if we are going to be true to our mission by practicing evidence-based medicine, that individual practitioners, and again, this is independent completely of theological and philosophical understandings of the human person. This is based solely on understanding of biology and evidence for best medical practice, that to compel a physician to give a medicine that one views the risk-benefit analysis as being contrary to good medical practice should be concerning to everyone who's involved in the medical profession. I think that's the most direct and significant threat that we're seeing by this, by trying to mandate that somebody delivers medical treatments that in a practitioner's professional opinion, based on the evidence that's available, could have irreparable and significant harm.
There was a second question related to all of this. And so let me get to that. One of our participants asked about the American Academy of Pediatrics, and specifically that they're asking physicians not just accept, but to affirm transgender people. How do we reconcile, especially with boards and academic expectations, the physician that has concerns, serious medical concerns about affirming as opposed to accepting?
And so in relation to professional societies, there's some important points that I would like to at least point out. That to be accurate in portraying what is being said, the statements that are coming out, as you noted in the question, are really coming out from a very, very small segment of the professional organizations. So that the question, the statement, the policy statements that are coming out from the AAP really have been put together by a small committee of individuals within that society. And it's never been brought to the entire membership of the AAP. As to whether one actually supports and agree with that recommendation. And so when we look at these statements that say that one must proceed in one particular manner. Now, I would step back and say there are many areas that we would have agreement with, and I do want to emphasize this, that we all are engaging in medical practice with the goal of helping the people that come to us for care. And so to say that we recognize their human dignity, that we desire what's best for them, is really at the heart of what everyone does. And so it's not an issue of rejecting these individuals or in not pursuing a particular medical intervention. Rather, it's the opposite. And again, this is often stated, if you don't affirm somebody, that you hate them. And that is an erroneous statement, that actually the way one is acting is actually out of love, and it is actually about concern about their well-being. There can be differences in understanding of what would be best for an individual, but we really need to dial back in the rhetoric and the conversation that's going on. We need to recognize that these professional organizations are made up of people with many different backgrounds, and that have looked at the literatures, most have not, and aren't familiar with much of the science that I've already presented and will be presenting in the next talk.
Related to that question is the issue of preferred pronouns. As you and I have discussed the issue, increasing hospital systems and physicians are being asked to honor preferred pronouns. To what extent? Well, I'll let you answer the question, but there is certainly a debate over the use of preferred pronouns. How should practitioners respond to that?
So, and then this gets back to what I only very briefly, mentioned about language. There are many aspects of that, of how we speak, that conveys not only underlies understanding of who we are as human persons, but has implications of how well we're able to be physicians. So that what is desired in using preferred pronouns is to accept one for the identity that they have. And one can understand this as far as that if one is biologically male and views themselves as female, that it would be very offensive, to deny that. Yet at the same time, as a physician, we need to recognize the sex of the individual that comes for our care in many ways, not only in addressing the issues of gender dysphoria, but also in providing good preventative care, pap smears in females, for example, and understanding, prostate disease in males are two very good examples of that. How does a practitioner engage an individual that respects them and their dignity as a human person without denying biological reality? I will share with you my own experience that when one uses pronouns that are different, convey something different than the biological reality that's present for that individual, it changes the way one thinks. And I think that there's an intention to do that, thinks about that individual. The one way that can be acceptable to recognize this difficulty is really to avoid pronoun use altogether. People often will, with a transgender identity, will adopt a name that is perhaps different than the name that they were given at birth. There's much diversity in names, and by calling somebody by their preferred name, one does not necessarily need to change their thinking about them as being male or female. I'm talking about it from the biological perspective, nor do they need to change their understanding, of what that all means. But it is a challenging what we're looking at, and we're trying to balance two conflicting goals. One is to provide the best medical care and to recognize the biological reality that's present for us. And at the same time, we're trying to recognize the true suffering that one experiences and the difficulty that one has with pronoun usage. I will say that when we would deal with children with DSDs during my training, when we were trying to actually figure out, this is the one rare circumstance where one does not have certainty about whether one is male or female. The desire was to use neutral language so that we wouldn't actually make any biased presumption about what the reality was or the defect that occurred. And in doing so, finding ways to be able to refer to the individual. For example, in pediatrics, one can talk about one's child. We can use their proper name that they desire without getting into the questions about pronoun usage. And so it's an individual decision that one needs to make based upon the benefits and potential risks of using that language.
You mentioned in your presentation that there may be other factors that are contributing to the increase in the prevalence of gender dysphoria. And you mentioned that there may be the increase in the facilities and medical interventions available. But are there other factors that you would care to comment on? Environmental, biological? There's some of our participants are speculating that there may be other factors in our environment that may be creating prevalence. What are your thoughts on this?
If we look at the phenomenon that is going on right now, and again, I mentioned very briefly, the largest increase is actually in biological females presenting as male, and that has really reversed the historical trends. The evidence, suggests very strongly, although it's not proven, that is a societal influence. And again, from a hypothesis standpoint, are these individuals that are going through developmental challenges that are then assigning that to gender dysphoria? There's also the phenomenon not only of having difficult developmental challenges, but there's also the, in many respects, celebration of people that are coming forward in that way. And there are many people that achieve the need that they have for recognition by having that happen. Now, related to the field of endocrine disruptors, it's one of the things that people have put forward as another hypothesis about sex steroids that are present in our environment. And there's a lot of literature on this and much that we need to learn about this. Whether that's influencing the brain as well, it certainly is a viable hypothesis. I would say that the evidence that's there is probably similar along the lines of whether it's an influencer rather than a determinative feature. Let me give an example. So the effects of sex steroid hormones in individuals that females that have congenital adrenal hyperplasia, they're exposed to higher levels of androgens, male hormones, in utero because of the defect that they have within their adrenal gland. Historically, those individuals have exhibited what people would call tomboyish behaviors. So they would have behaviors that would be more masculine, yet until recently, the vast majority of those individuals never experienced any gender dysphoria or denying their biological sex as being female. And so again, seeing that condition where we have sex steroid influences being different, that the rise itself is almost clearly not due to genetic mutations suddenly becoming more prevalent. That is not something that occurs in that with that rapidity, going from something that was a fraction of a percent to having people, by some statistics, 2 to 3% of the population questioning their gender identity. It's been a huge increase. And so many questions that need to be asked, research that needs to be done. We need to be aware of how we define these individuals. We need to actually it's become challenging to even ask the questions that one needs to understand what is going on. And what do I mean by that? For example, the psychological, history that one would normally provide for other psychological issues is often looked down upon or restricted from occurring, so that any challenge to one's transgender identity is seen as a threat. So to be able to explore whether they had changes, they had subjected to sexual abuse and things like parental divorce and all of these bonding issues that occur are often not explored. And so again, many questions, very few answers.
Bill Shaw, who is a colleague of yours, asked really a collective question from a number of participants, wondering if you could tease out a little more thoroughly the twin studies. Let me read to you. He's wanting to know, can you tease out the concept of hereditability in twin studies, and also with the 38% concurrence in JD or gender dysphoria in identical twins, what's the breakout of that 38%? Is it 20% genetic predisposition, 40% common environmental factors, or 40% of unique environmental factors?
That's an excellent question, and it really reflects the limitations of that data as a whole. All we can say is that there is a higher concordance between these individuals. There are, the best, ways to sort that out. You can't. To be able to look at the environmental influences, the prenatal and perinatal influences versus the postnatal influences, because again, a child born at birth is not declaring themselves with a gender identity. We are looking at biological sex at the time of birth. Again, looking at the genetics, there very clearly are at least hints that there's environmental components, but accepting that there are genetic influences as well. If it was genetically determined, that number should be 100%. So that if you had 100% equal genetic information, then that concordance rate would be in every individual, there would be a shared experience of that. So that the fact that it's not 100% clearly points to environmental influences. The challenge is that with the numbers that have been looked at, and we have more abilities to do whole genome sequencing on individuals. In fact, there is a study that is going on to do exactly that, to look at transgendered individuals and look at the entire genome and be able to look for differences. In fact, there have been a couple of papers that have been published, reporting, making the claims that they've identified the biological component. One of them, for example, that was published, looked at polymorphisms or differences in the genes related to sex hormone synthesis. That study, had very significant limitations in the statistical power that they had to be able to make the conclusions that they did. They had multiple comparisons, and when you did the proper statistical analysis, all of the differences actually became non-significant. But because of the complexity of sexual differentiation and also the layer of genetic influences on behavior, and how many genes are likely involved, it's going to be a very, very difficult problem to solve. And I think that, again, I pointed out the same-sex attraction data because over many decades, people have looked for and asked that precise question about genetics versus environment. At the end of the day, it was very clear that there is not a single genetic locus that directs this from occurring. And understanding, the more we understand about the differences in the genetic contributors, could have a profound influence on how we approach the treatment. As we understand etiology, we know this in other areas of medicine as far as those that respond and don't respond to various medications. If it's a heterogeneous population with different genetic mutations, some will respond, some will not. It creates difficulties in looking at outcomes when you average that out over a larger patient population, and you may conclude that there's no effect when there really is a beneficial effect and you just haven't recognize the difference. And this includes not only, again, we're going to talk about specific interventions, those that would respond well to psychological approaches versus medical hormonal interventions.
Our final question for this particular segment of Q&A, Dr. Hertz, Dr. Roos, is the question of academic challenge to your presentation. Have you been in a situation where your findings and your thoughts on this issue have been challenged, and what has been the nature of that challenge?
Again, happy to have the chance to address that. I have not had anyone challenge the scientific information that I present. In fact, when I've presented the actual data, I'm getting beyond the rhetoric and beyond the statements that are made repeatedly about that are mostly based on ideology into the actual data itself. I've never been challenged in the points that I've made related to that. And I think this is what we do as physician scientists. When we actually look at data, we recognize, as scientists, we recognize the limitations of any scientific study of evidence. We're often questioning. And I think that, from that aspect, I've really sought out frequently to be able to engage in that conversation about looking at the actual evidence, acknowledging the strengths and limitations of various studies. But the general interaction that occurs is to, and it reflects actually how this is a distortion of the way that we normally do practice scientific investigation and research, is to make an ideological statement and to discount the discussion before it even begins. One example of this, is that when you look at many of the studies, and I'll show you specific examples in the next segment of the talk, of papers or studies that were done, papers that were published, and conclusions that were made that are not supported by the evidence. And so what frequently is going on is that one has a preconceived conclusion. One is not, again, we talk about, objectivity, and one is not willing to look objectively. We all have biases. Any scientist knows this. That does research. And one of the things that we need to do when we engage in scientific investigation is to minimize as best as possible those biases, and to set those aside and recognize where they exist. So I'm at a major academic institution where we pride ourselves on high quality research and evidence-based medicine. My conversations that I've sought to engage in that conversation at that level is one that should be welcomed everywhere. Many of the colleagues that are involved in this discussion recognize that, but they aren't speaking out about this. And those that do often do from an ideological perspective. I recognize, where that is coming from. I accept that as far as the challenges that are there. I've never felt threatened more, but challenged to how I can best raise the level of discussion to that which is required for us as physician scientists.
Thank you for your candor, and thank you for your willingness to stand in the gap between ideology and science. We appreciate your first presentation, Dr. Roos, and look forward to your second presentation shortly. Folks, we're going to be taking a 10-minute break, and following that 10-minute break, we'll start immediately. So thank you for your attention this last hour. We look forward to you joining us in about 10 minutes. Thank you. Welcome back, everyone. Welcome to part 2 of our morning's webinar on clinical aspects or presentations on the gender issue related to what Dr. Roos has been doing research on and speaking to for the last 20 years. You're reminded that if you have questions, you can use the Q&A box at the bottom of your screen to supply us with questions. We will do our best to try to get to them. There are some duplicates or at least related questions. We'll try to respond to those as best we can. One thing you should note, some of you have asked about theological and biblical aspects of the issue of gender movement. We had a part 1 presentation in October of 2020 by Dr. Andrew Walker, who spoke to that issue in depth. And we're going to make that part 1 presentation available to you when you log on to part 2. Part 1 will also be available at the same location. So when you receive notice that part 2 of this presentation is made available to you, you should be able to find part 1 at that same location, same time. So, Dr. Roos, we're looking forward to your second session with us.
Very good. Well, again, thank you for your attention during that first session. Really much of what I discussed in that first session is going to be very, very important as we proceed to this topic of the medical treatment paradigm that is being used. And again, I want to focus on scientific evidence. I will point out where the areas of ideology have impacted the science, but really stay focused on our topic at hand. Again, I want to disclose very clearly that I am not representing Washington University or St. Louis Children's Hospital in my comments today, although I am talking about matters of medicine and best medical practice. I want to begin this segment by really directly acknowledging that the whole reason why the medical profession is involved in this conversation is because the people that experience gender dysphoria have true and real suffering. And I don't think that this is at all controversial. A very high incidence of suicidal ideation and suicide attempts and even completed suicides, a very high incidence of substance abuse, eating disorders, anxiety, mood disorders, sexually transmitted diseases, including HIV, having been exposed to domestic violence. So all of these are reasons why we engage. These are patients that come to us that are crying out for help. They are seeking alleviation of their suffering, and that is why we are discussing this here today. The question that we're going to ask is, what is being offered to these individuals, and is it truly helpful? Not only does it alleviate the suffering in the short term, does it long term improve their well-being, health in doing so. And as we talk about this, we're going to spend most of our time talking about the primary prevalent approach of affirmation and the medical aspects related to that, because that's really where the medical profession has been asked to engage. But I want to acknowledge that that is not the only approach, and that there are actually, you can divide them up into 3 different approaches, and really each of them differ. They differ in many ways in the underlying scientific and ideological premises that are present in that approach to care. The first that I'm going to mention is often referred to is the reparative approach, and it has other names, but I think it's probably more commonly understood with a goal, an explicit goal of assisting an individual to realign their gender identity with their biological sex. And the reason for this approach is it's based upon that the problem itself, the premise that the problem resides within the mind and not the body. And this is what in the DSM-4 was the understanding that we had for this particular condition. And that's not to say that one accepts that one is going to be successful in that outcome in every individual, but it is stated as an intentional goal. And as a goal, the focus is on psychological interventions to alleviate that distress and to understand what the underlying contributors were to that presentation. And it really directly involves, looking for prior abuse and trauma, social influences. What's important to recognize, and many people state that this approach is ineffective and in fact harmful. And really, it cites, and many of the organizations that dismiss this as an approach cite literature from decades ago using outdated psychotherapeutic approaches. And many of the modern psychotherapy approaches have not really been investigated. And there really are data that are available, even in that older literature, that some individuals did have that outcome and actually had a very good outcome from that, but it's a very small percentage of individuals. And this is an area that really has not been investigated. And not only has it not been investigated, it has been stated that one cannot even engage in that as a hypothesis. And I'm not, again, not making any judgment on them. I'm just presenting them objectively as far as what the approaches are. The second approach to treatment is known as, or can be referred to as the expectant approach or the watch and wait approach. The premise or the basis for this approach, and again, talking about it in the pediatric realm, is that the vast majority of individuals that present with a discordant gender identity from biological sex pre-pubertally in childhood will have spontaneous realignment of their gender identity with their biological sex or desistance. And again, this has been challenged by many individuals with not pointing out that the quality of the evidence in nearly the dozen studies that were done over a period of many decades consistently showed that same response. The actual number varies from 50 to 98%. I use the number 85 because that seems to be the best average of the data that is there. And again, this is without any desired outcome. So these are just some of the newer studies that I can cite. Where this outcome has actually been observed. And again, peeling away any ideology or desire for this not to be the case, this is what the literature shows. And the reason for the expectant approach is that if one has that outcome, they are not going to need to experience all of the potential risks that we're going to talk about in the affirmative approach. So that if you have this realignment of your gender identity with your sex, you're not going to need any further treatment or be tethered to the medical establishment for the rest of your life. And in fact, even in the practice guidelines that are put forward, previously it had been the preferred intervention in prepubertal children. Now, it is a different situation when we're talking about adults. Again, I'm specifically talking here about children. So now the third approach is what we're going to spend most of our time talking about this morning. And this is the affirmative approach. And it's often referred to as the Dutch model because of how this approach was actually first proposed and implemented. And again, the premise here is that the gender variation is a normal part of human biology, that it's necessary to alter the body to conform to one's gender identity. So that is, again, an assumption that is made, a premise in all of this. And so what does that involve? It involves really a shift in our understanding of puberty. For these individuals, the puberty that occurs at a normal time, what we refer to as the biological changes that from childhood to adulthood that leads to reproductive competence, rather than being normal, is abnormal for these individuals. And so the first component of that approach is to give pubertal blockers, and we'll talk about the data and what that means. The second component is to give cross-sex hormones, and traditionally that had been proposed at 16 years of age. The move has been to offer these hormones to children, adolescents at younger and younger ages, trying to minimize some of the adverse physiologic consequences of prolonged pubertal blockade. And by that, I mean, giving testosterone to a biological female and estrogen to a biological male. And then along the affirmative approach, it leads to surgical interventions, traditionally been proposed at 18 when the child is able to consent to those procedures. As many of you will know, this age has been lowered in many respects, and there's a push to move it to younger and younger ages. The vast majority of people that have surgical interventions involve what we call top surgery, bilateral mastectomy, in biological females that desire to appear male. There's also breast augmentation surgery that is done in biological males desiring to appear female. And then a much smaller subset of patients that will choose to have the bottom surgery or the change in the appearance of the external genitalia. Now, that's just the outline. I'll go into more detail about specifically about the hormonal interventions in the time that we have here this morning. Much of what is being discussed and proposed is being codified, as I think one of the questions in the first session related to this, by clinical practice guidelines that have been put forward by major professional organizations. And I just list three of them here. The World Professional Association for Transgender Health states them as standards of care. That's actually an erroneous term. They're actually, you can challenge them as being standards. They're guidelines, and they're actually in the 7th iteration of the guidelines. They've been around for many years, and there's an 8th iteration that's currently in the works that may be coming out by the end of the year. My own professional organization, the Endocrine Society, put out guidelines in 2009. They revised them in 2017, and we'll talk a little bit about the evidence that's present in those guidelines to be able to understand the strength of the recommendations that are being made and the evidence that's available to support that. Now, let's just briefly go over what that means. So in any good clinical practice guideline, if it's done properly, the authors will acknowledge the actual studies that were used in making those guidelines. Guidelines are proposed because there's often large and conflicting information that's present in the literature. There's a lot of information to synthesize for practicing physicians that don't have time to read the primary literature. So it's kind of the Reader's Digest version, and people go to the guidelines to say, how should I act? It's necessary to remember that the hierarchy of quality of studies, from expert opinion to case reports, all the way up to the gold standard randomized controlled studies, and doing meta-analyses to combine together different studies that are done in different populations. Within the Endocrine Society guidelines themselves, they use what's called the grade system that rates scientific evidence from a very low to high, based upon, and I want you to just in this slide here, be able to recognize what the implications are of the strength of the recommendation. Okay, that if it's very low evidence, that any estimate of the effect is very uncertain, and really that there's a high likelihood in the low category that as new evidence becomes available, that the guidelines are going to change, as opposed to high level evidence that the data seems to be consistent and strong enough that it's highly unlikely that things are going to change. Why is that important? It's very clear that in many areas of medicine, guidelines have been proposed that have actually undergone significant revision. In fact, some areas of recommendations that have gone about 180-degree change. And again, the examples of that, could be, giving sex steroids to postmenopausal women, or steroids to people following a traumatic spine injury. And again, well, we have to recognize that when we're talking about the area of transgender medicine, invariably the evidence that's being put forward is in the category of poor or even non-existent. In the Endocrine Society guideline, nearly all of the recommendations that were made were based on low or very low evidence. The only areas that were put forward with moderate evidence were actually due to side effects or adverse effects of that intervention. So what are the limitations in general with the existing research? The slide about few overall studies, there's been an explosion of studies being published, but many of the studies that are still coming out are of poor and limited quality and involving very small sample sizes. A couple of the larger studies I will highlight in this morning. Many of them have significant biases in the patient populations that they're looking at. And one of the most significant concerns are what's known as convenience samples. So when you do an internet survey, that you're not taking a systematic look across the entire patient population, you often will recruit patients that have a particular interest in the study. And the best example of that is the US Transgender survey, which is one of the largest sample volumes, but patients were recruited through the internet and with a snowballing recruitment effort to really, and then also having an inherent bias in showing adverse effects of their relationship with other people. Many of them are very short duration. That's going to be very important as we consider studies done in children, or when we look at the potential impact on the most significant concern in this field, and that is of suicidal ideation and completed suicide. Observational in nature. What is lacking in these studies are the gold standard scientific studies of randomized controlled clinical trials. Many people argue that they cannot be performed within this patient population because of the risk that they're going to commit suicide if they're randomized to anything but the affirmative approach. And that's really, has many errors within it as far as understanding what we mean by controlled research, and that when we talk about control, it doesn't mean you don't do anything to the control arm. We'll talk about that in more detail. Now, before I get into the hormonal interventions, I want to start with the first step of the affirmative approach. And it's actually not a medical intervention, but it is one that the medical profession is being asked to participate in and provide, but it extends into the wider community. And for many of the people in the audience are not in the medical profession, but will encounter this in schools, in churches, and in other settings. This relates to one of the questions in the prior session about pronoun usage, changing names, cross-dressing, access to bathrooms and other intimate facilities that are designed for one sex versus the other. And in the area of medicine, even changing the electronic medical record and referring to that patient according to their gender identity rather than their biological sex. And the social affirmation is advocated at very early ages, as early as kindergarten or 3 years of age, even pre-kindergarten. And again, looking at the data and looking at the natural history, what is that influence going to have on that individual, on how they work through gender identity issues over time, is something that has not been studied in a rigorous way. So let me just say very clearly, what is the scientific evidence for social affirmation? It really, again, like all areas in this particular topic, it's low quality evidence. There's a handful of short-term studies that do show a reduction in dysphoria in people that are socially affirmed. And again, one can ask questions about that alleviation of the dysphoria, akin to if someone has a developmental challenge or any other challenge, and you remove that challenge. The example I often will give, as a child in school that is struggling over a math exam, and if you tell them that they don't have to take the test, their anxiety is going to be reduced or go away related to that. The question you have to ask is that in doing that, you've then prevented them from having that experience that may be beneficial to them in the long run. There have been no long-term studies that convincingly show that this approach is good. And actually, there are studies that show that that long-term depression and suicide remain markedly high, and much of this data is in the adult population. We don't have this for children. One of the prevailing hypotheses as to why they have depression and suicide is because of social stress. It's a valid hypothesis. There's many pieces of information that one can use to challenge that as the main or sole reason for depression and suicide. And there are definitely alternative hypotheses that one can propose. So really, there's, for example, the bathroom use in schools, no randomized controlled trials, or the same thing with pronoun usage. And again, one of the concerns is that by socially affirming a prepubertal child is that, will you be driving them along the pathway to later interventions? So let's talk about that next step. When a child is experiencing gender dysphoria and they begin having the bodily changes of puberty, many times these children will have increased dysphoria related to that. It's an unwanted change. And people have proposed to give what's called GnRH agonists, or known as puberty blockers, to disrupt that process. And it's based on a longstanding data that we have in treating children that have abnormally early puberty, and to be able to suppress that. So we have a means to be able to do that. These are the reasons that are often cited for pursuing pubertal blockade, is it being safe and fully reversible, alleviating dysphoria, and giving that child more time in their gender identity, and also used in the diagnostic phase. Important to point out, there is no single biological test that one can do as a physician to know whether an individual will have desistance or persistence. It's based solely on the subjective experience of the individual. There's no way to be able to even confirm that diagnosis aside from that child's assertion. And then the other rationale is if you're going to pursue cosmetic changes, surgical interventions, it's going to make that easier or less necessary to do. Now, I'll refer you to a paper that I published a couple of years ago with my colleagues, Larry Mayer and Paul McHugh, in the New Atlantis, that goes into more detail about these difficulties that we have in the use of pubertal blockade. Let's begin by just talking about this a fully reversible claim. What we are doing here now, the claim is that if you give the puberty blocker for a number of years and then you stop it, that the signals coming from the pituitary gland to tell the gonad to work will resume. And in general, the evidence that we have is that is indeed true, but you're interrupting a temporally dependent process. So biological puberty occurs at the same time as the social changes that occur, known as adolescence. And so it is not possible when you interrupt that developmental trajectory to buy back time. So by that logic alone, this is not reversible. To say that it's safe, it's not been studied or approved by the Food and Drug Administration for use in suppressing normally timed puberty. We don't have the data of sufficient quality to make that claim. So it's erroneous to say that we know that it is safe. And in fact, we do have emerging evidence that shows that there are significant side effects. One of them would be the effect on bone density. So puberty is a time where the maximal bone density is accrued for an individual that's going to carry them for the rest of their life. And if you miss that opportunity from the effect of the sex steroids, you're at markedly increased risk of osteoporosis later in life. Probably the biggest concern is that if you block the development of the gonads, the continued maturation of the gonads, and then you follow that up by cross-sex hormones, so the gonads don't fully develop, the expected effect is going to be infertility. And in fact, the people that are delivering this care know this. In fact, it's contained within the consent forms that they give when they engage in this treatment. There are entire programs that are developed to be able to help individuals with fertility that is impaired as a result of this intervention. So this is really clearly not controversial. It does exist, and very concerning, because we're asking children to make these decisions about their lifelong fertility at an age where one could argue that they don't really have a concept of what they're giving up. And then again, as I mentioned previously in social affirmation, the concern is that the desistance, the normal desistance that we see in individuals will be altered. And I think that there is emerging evidence that supports that. In one of the big studies that was done, or not big studies, it was a very small sample population, 100% of the individuals that received puberty blockers went on to get cross-sex hormones. I think that by most estimates in the data that's out there, about 98% will go on to get cross-sex hormones, a very different outcome than the other literature, the older literature showing that there was a much higher desistance rate. So again, with all the implications of giving the cross-sex hormones, one can certainly question that information. So I promised you that I would show you some data, and I want to give you another concern. Not only are the studies themselves limited and have limitations in themselves, in response to one of the prior questions, even what is being put forward often presents conclusions that are not supported by the literature. And since we're talking about pubertal blockade, I want to highlight a study that came out in the journal Pediatrics, one of the flagship journals of the American Academy of Pediatrics. It was actually voted one of the best papers of the year for the journal, which made the claim that puberty suppression decreased the risk of suicidal ideation. This became prevalent in many news outlets, many headline banners saying that it's linked to lower suicidal thoughts. Now, if you actually look at the data that was present in that paper and just critically evaluate it, there were many limitations. It was a biased study population, the US Transgender Survey, a very serious limitation of missing data, patients lost to follow-up. There was a multitude of variates that were compared, limiting the statistical power of the analyses, and many of the sub-analyses had not sufficient power to make conclusions. And because it was cross-sectional in design, did not allow one to say a causative relationship, only could they say association. And more importantly than that, when one looked at suicidal ideation in attempt within the past year, so current suicidality, it remained very high and not statistically different from those that received puberty blockers. So whether you did or did not receive the intervention, you still had a high suicidality. And again, I won't go in the detail that we have, despite the claim, the study does not provide evidence to support that the puberty blockers really are helpful. And that's very, very important, because the take-home message was we've established that this is helpful. I'll say one more comment on that, that it may be very possible that those that did not get the intervention had other issues going on that prevented the clinician from offering that as a form of treatment. So what they showed is that throughout their entire lifetime, those that did or did not receive puberty blockers had a different lifetime suicidality, but it didn't show that difference in the current situation. Let's move on now in the time that we have to talk about the cross-sex hormones. And again, there's so much that I could present to you about what is known and some of the questions that are there related to the risks of cross-sex hormones. Here, I think it's very important to draw back on the first talk to recognize the differences between males and females biologically and the response to hormone intervention. Because of the genetic and epigenetic changes that occur between males and females, we know that there's a marked difference in susceptibility to various diseases. We also know that there's a very marked difference in responses to various medication interventions across the board. It's one of the reasons why our National Institute of Health requires one looking at new drugs to study both males and females, recognizing that the effects may be very different. So it's not accurate to say giving testosterone to a male is the same thing as giving testosterone to a female. What are the known and potential risks of giving cross-sex hormones? Just very briefly. We already talked about infertility. Very well known that if you give estrogen to a biological male, you increase the risk of stroke by about 5-fold. which can lead to neurological impairment and even death. Polycythemia, elevated red blood cell count, and giving testosterone to biological females. Very significant effects on bone density. There's a lot of literature out there, some more studies that need to be done. Very clear in emerging data on cardiovascular risk. We see a lot of markers and metabolic outcomes, insulin resistance, diabetes, lipid abnormalities, as an effect of these hormone interventions. In treating children, the data is way too early to be able to look at myocardial infarction or heart attacks as an outcome. By acne, disfiguring acne, very, very significant acne. And then in the area of cancer, there's two areas to point out, not only the biological effects of giving that cross-sex hormone, but also when we look at individuals that are presenting as a sex that is different than their biology, often are not getting screened for cancers, for example, pap smears in biological females when they're presenting as males and being missed in that. The list I have are just a few of the many papers, and there's more that have come out recently as well that raise many concerns. Now, the reason this is not necessarily controversial, although there are studies that try to paint the conclusions on the data that minimize these effects, it's recognized that there are significant risks. And that's not unique to this patient population or this particular intervention. All medicines that we give have risks and benefits. What is often put forward is that because you're trying to alleviate suicidal risk, that we can accept these other risks to be able to prevent suicide. So let's just look at that claim. We don't have the data in children. We don't have the long-term data. It's a proposal, or the affirmation approach is so new that we don't have that data, but we do have data in adults. And again, these are just a few of the studies. The one that's frequently cited is the Swedish study by Dane and colleagues. With the Swedish population, really the medical system, keeps track of really all medical information. And what we find is that a couple of very interesting points here. So that this is many decades after they've been received either hormonal or surgical intervention for their gender dysphoria, and this is that there's actually, if you look at completed suicides in that patient population after you receive this intervention, 19-fold above the background population. Because this is not a controlled study, you cannot conclude from this study whether the intervention itself led to that outcome. But what you can say with confidence is that whatever was going on, it did not solve the problem. They remain highly likely, much above the background population in their suicidal risk. The other important point here, if you look at this as a Kaplan-Meier curve looking at the causes of death in this patient population, and I'll point out to you that it's over 10 years out from getting this intervention where we start seeing the separation between the treated and the untreated groups. And again, in the area of pediatrics, we haven't been engaging in this practice for long enough to really get to that point in time. And if you ask many people that find out that have been undergoing this intervention that seek to have reversal, they have desistance in their this is just showing you the actual data. I'll go over that in a minute, that it can take up to a decade before they actually come to that conclusion. Now, again, as I said previously, many people will ascribe this to social stress. And I'll point out that when you look at not only compare the Dutch population or the Scandinavian population to the North American population, very different cultures as far as acceptance of this condition. This is a meta-analysis that was published in 2017, looking at a number of different studies looking at suicide outcome in North America. And I'll point out, again, this is trying to synthesize data, but what you can see here is that when you look at lifetime suicidality, similar to that pediatrics paper that I showed you, in comparison to suicidality within the past year, you see that there's still a markedly increased risk over time, and it doesn't it really corroborates the data that was found in the Dane study. The very few studies looked at before and after effects, but actually was in the few studies that looked at that, suicidal ideation was increased after this affirmation. So we certainly need to question that. I want to point out one other recent study to illustrate again, as you are looking at the literature here, and the statements are being made that we've established that this is the right approach to do, that the science shows that this is beneficial for this patient population. Again, pointing out some of the ways that the data is being presented in an inaccurate way. It's not to criticize the study itself, it's more than the interpretation. This is a study that came out again last year with the lead author, Brandstrom, trying to look at after, this is again in a Swedish population, looking after they've had either hormonal interventions or surgery to see how often they would present for ongoing psychiatric care. And if you look at this curve here, the point they were trying to make is that for being hospitalized after a suicide attempt, that went down over time, and that over time, the seeking mental health was decreased as well. Now, this is after surgical intervention. In the study itself, they had already concluded that hormonal interventions were not statistically different in that readout of presenting for mental health care. Because of the way the study was done, there was much fewer patients in these later time points here, really impacting the outcome, to the point that if you had just a few patients that had a different outcome, it would have drastically changed the conclusion. Doesn't take into consideration, even consider that this dropout here in suicidal attempt might not reflect the fact that patients had completed suicide and they were lost to follow-up because they weren't able to present if they were no longer alive. And because of many of the limitations, some that I don't have time to present, we can see that there was a request by a number of different investigators to challenge the data. The authors went back and looked at a better control, maybe not the ideal control, since this was a retrospective study, comparing it to between people that did or did not receive surgery. And when you did that comparison, there was no difference. So in the end, the conclusion of the paper is, or should have been, based upon the data, is that hormones and surgery do not alter the need for mental health, seeking mental health treatment. The authors themselves didn't merely acknowledge that perhaps they overstated the strength of their conclusions. And again, the desistance question is out there. People may know this individual. His name is Walt Heyer, lived his life for many years as a female, and again, has a very compelling story about his coming to understand that it didn't solve his problems. He's got a website where he engages many people that come to that same conclusion as adults. And there are some published literature, a very small segment of the population that has been in the literature, a growing number of people that are reporting this. You may have been aware of the recent Kiara Bell case in the UK, where a child was subjected to these interventions and came to realize that it didn't help, and really illustrates the problems in engaging this in patients, and especially in children that are not able to consent to that intervention. Let me just wrap up now, because I know that there will likely be many questions, and there's so much more that we could cover on this topic. And this is just going to be a recap of many of the things that I've already said, that people who experience a gender identity that is discordant with their biological sex, we need to remember, and we should not forget, that they are really suffering. We need to be compassionate and understanding, and seeking to find solutions to alleviate that suffering as best we can. The etiology of sex gender identity discordance remains unclear. Information could be very helpful if we're searching for that to improve our ability to help this patient population. Many ideological assumptions that are influencing the discussion on this topic, really at the detriment of science and best medical practice. The current scientific evidence supporting the affirmation-only approach is very weak. And I would say as much as that this is still an experimental approach. It's not presented to patients as being experimental, but if we were fair in approaching this as we do in other conditions, we would acknowledge that, and then then enroll them in very controlled studies with the safeguards that we normally provide for all other research subjects. And so that the suffering is not, from the evidence that we have, does not go away for a large number of these individuals. And certainly there's a need for much more science and unbiased science in critical analysis of what is going on. Now, I know that many of you are asking questions, what can you do outside of the medical arena? And I'll just throw out a couple of general thoughts, and maybe we can talk about it in the question and answer session. I think we can all agree that because of the suffering that they're experiencing, that we need to maintain that compassion. And I think there are indeed injustices that occur within this patient population due to ignorance, prejudice, discrimination, bullying. And I think everyone, would in this group would agree that that is not should not be tolerated, and we need to work to eliminate that. Yet we need to, at the same time, provide quality evidence-based support, including psychological support. And that's one area that even if the goal is not to change the gender identity, these other areas of suffering, including depression, anxiety, and the like, can benefit from this. And that that the education that we can provide in understanding all of the dimensions of human sexuality and how that plays in. Many of you that are listening in have expertise in other areas that can contribute to that discussion. But we need to maintain, understanding of the truth regarding human biology if we're going to be successful in providing the best care to these individuals. And before I go to the questions, I did put a couple of links here that of places that you can go to on the internet. We'll provide that for you in addition to what's available. I think there's some very good information. I want to reach out and acknowledge Andre Van Mol and many of the other members of the task force to put together a very extensive fact list on some of the data that I presented today in much more detail of what the scientific evidence is or is not in this area. And then some other areas that one can go to for further reading. With that, I'm going to wrap up. And again, I thank you again for your attention this morning and look forward to your questions.
Thank you again, Dr. Roos, for very enlightening, very helpful presentation, very practical as well as scientific. One of our participants asked the following question: have you had to treat children with hormones for the purpose of changing gender?
As a physician, in my role as a pediatric endocrinologist, we cover a number of different hormonal conditions. The care that has been set up in most institutions has evolved into specialized gender clinics. And as a physician scientist, there's a strong desire to participate in the design and conduct of the proper medical studies. But because that has not been proposed and implemented in the controlled research environment that I believe is necessary, and because the analysis that I have made as far as risks and benefits doesn't justify this medical intervention, just as I would in other areas where I've had similar conclusions, that I don't feel that it's a prudent way to proceed. I certainly have cared for individuals that have other endocrine abnormalities, diabetes, lipid disorders, and other endocrine diseases. So and again, this is something that all practitioners in their practices will choose to offer different types of interventions within their area of expertise based upon evidence available. Most of the patients at my institution, actually all of the patients at my institution, are referred to the specialized gender clinic that has been set up and that has been set up in other areas. And because of what I've shared with you this morning, aside from a desire to participate in some of the necessary research, my practice has been confined to the other areas of pediatric endocrinology.
We had a question from our participants pertaining to gender affirming decisions that are being made. For example, The gender affirming approach is clearly the most popular model at this time. To what do you attribute this popularity, and has research and activism merged in this area of research?
Well, I would say that in other areas of the world, people are now beginning to question this. So it is the prevailing approach in the field, and certainly in the United States and in many other areas as well. But many are raising the same questions, and really calling into question the data that's available. In fact, even some of the regulatory agencies here in the United States don't have evidence to be able to support that intervention. To the extent that this is based on a desire to do something beneficial to this patient population, I think that that's across the board. The people that engage in this care are truly seeking to do the best for these individuals. But I think that the ideological assertions that are being made, many of the recommendations are being made by a very small segment of the medical profession that is clear in their unwillingness to look at the data that I've shared and engage in that conversation reflects an underlying bias. There's another component to this, so that it's often said that if you're a surgeon and you have a knife in your hand, your desire is to cut. If you're an endocrinologist, your desire is to be able to intervene in hormonal systems. So we have this desire to do something because we see the suffering that is going on. So we generally turn to the toolbox that we have at hand and be able to apply that. And sometimes this is done thoughtfully. Hopefully, most of the time this is done thoughtfully, but sometimes it's done without carefully considering what we're doing. What's missing in this conversation is the critical role of the psychologist and the psychiatrist in addressing these issues and their role as well. And again, it's often used as a means to kind of exclude other psychiatric conditions going on, but check the box that they fulfill the DSM criteria and then move on. It doesn't mean that we don't provide psychological support, but the preeminence of that contribution is been minimized. And I think that what I've seen is based on more ideology than it is on science. And so there's certainly much more that we need to hopefully raise the level of conversation and acknowledge that limitation, and look at this objectively. And this is, I would say, a threat not only to transgender medicine, it's a threat to the entire practice of medicine. We're seeing the way that our healthcare system is set up. Physicians are very busy. They often look to the Cliff Notes versions, the summaries, of how to proceed, and don't have the luxury of being able to look at the data. So that's one of the reasons why this has become the prevailing approach, because the guidelines have been put forward to say that this is the only approach.
A question from one of your colleagues. Are your colleagues at Washington University and in your field aware of your Christian orientation and worldview? And what is your level of concern that at some point you could become a target of cancel culture?
Well, one of the dangers, I think that people know me very well, and I'm not very shy about my being a Christian. The danger is that they attribute what I say on the area of science and medicine solely to that worldview, and they dismiss the scientific arguments outright before even considering them. It doesn't bother me one bit that one is perhaps uncomfortable, with my being a Christian or attacks that. I'm not bothered by that one bit. But what I'm very concerned about is being able. What I've shared with you this morning is a scientific evidence, medical evidence, evidence-based medicine, independent upon any philosophical or theological underpinnings. We need to recognize that we all come at our understanding differently. I think it's most effective that when I approach this, that I acknowledge my Christian understanding of the human person, the many aspects of human sexuality that move beyond the biological, and by acknowledging that, then I can be more objective in making really the best decisions for the patients that I served.
Fast forward 8 to 12 years from now, do you foresee a backlash on the part of both patients and parents concerning the hormonal therapies that are being encouraged and the affirming approach to gender dysphoria?
Well, I think that at least looking at the data that we have with the hypotheses that we can generate based on the evidence available, I think it's almost certain that there are going to be, just like we see in the adult population, those that recognize many years out after having the affirmative approach applied, that they are continuing to have difficulties, and that experience this desire to reverse the changes that are done. I think the Kiara Bell case is a prominent public indication of that, which really is just one of the first cases that have come to light. But certainly there are many other children that are really seeking these interventions. And so in the situations where the care and the caution has been dismissed, and the push to get them on hormone therapies is almost certainly going to lead to that outcome. One of the areas, and again, just to maybe build on that a little bit, the experience of people that I've interacted with that have felt that what the affirmation approach did for them did not help them, when they expressed that, even the doubt or the desire to reverse what went on, the level of animosity and really difficulty that they've experienced by those people that were pushing them to have the intervention is quite significant. And many of them have been reluctant to be open about that, just as we have individuals that are experiencing gender dysphoria previously would not make that known. We see that in the same area of people that experience this or desire this detransition. And looking at the detransition, it's either my gender identity has changed, the true desistance, or the recognition that the intervention itself didn't change that experience. So there's so much more that we're going to see as time goes on, particularly, so, sorting out those individuals in that category prior, to this current social phenomenon, is a small subset. If the hypothesis is true that many people are seeking care that otherwise would not, that's a different patient population. And we know even less about this population, the adolescent females, presenting about what their outcomes are, because this is a relatively new phenomenon. So the simple answer is yes. I think it's almost certain that we're going to see that. It's not clear what the magnitude is going to be. And, I would often say that one of the largest studies that are going on in the pediatric world is an observational study funded by our National Institute of Health, without really a hypothesis saying we don't know what's going to be the outcome, so we're going to follow them over time to see what that is. And the concern is that if it turns out at the end of the day that many children weren't helped and many of them were truly harmed, the question is how many of them will that occur? And that's why I think it's so critically important to continue to understand this as an experimental approach to treat a very serious condition with very serious effects long term.
Are there studies looking at detransition, perhaps looking at prevalence, possible predictive factors, or mental health outcomes?
Well, I think that this is an example, again, of where the politics have really interfered with science. Individuals that have tried to study this actually have been prohibited from doing so, even people that are at academic institutions. So this is being put forward as a topic that's off limits for study, at the detriment of those individuals that are affected. That how the studies are conducted is a very, very valid concern, and we need to make sure that all of the safeguards that are in place when we engage this patient population are followed. But to say that it's a topic that can't be studied, or because of many institutions, for example, are unwilling to allow that research to be done because of the desire not to bring attention to that. It's the same thing that occurs at the personal level for people that are experiencing this detransition, that that when there are complaints about asking the questions, they're being told that you shouldn't even ask that question. It's basically saying that we've answered the problem. We have all the answers. We should stop doing the research because we don't want to we don't want to have any other outcome than what we desire. So I think that there is a tremendous need for that to be done. To my knowledge, most attempts to get that research done has been actively suppressed, unfortunately.
That's mirrors a question that was posed earlier. Do you think because of this issue, that has become so politicized that the prospects for any kind of well-done research, longitudinal research, any kind of research is really going to be difficult, if impossible, at least in the US?
Difficult, yes. Impossible, no. Science itself is inherently self-correcting. There's many things that have been published in the literature with limited data that have reached really erroneous conclusions and not necessarily in a malicious manner. With time, we're going to see the experience as we learn more and more about what is going on, as we understand more about the etiology, being able to segregate out patients with different contributing factors and see the natural history of what occurs. The outcomes will happen, the question is how long it's going to take, and depending upon the number of individuals that are subjected to a particular intervention, how many are going to be affected, so that if that is true, the science does not proceed in the future, it's to the detriment of the entire medical profession, because no doubt that's going to spill over into other domains as well. So I think there are enough physicians that uphold to the principles of evidence-based medicine and best medical practice. The challenge is that those that understand that and the importance of that have largely remained silent. They all agree about the questions and concerns, but because of the intimidation, they're not voicing those opinions. That's what's going to be necessary to move us in the direction, is that those that are able to engage in the conversation for the reason that we do anything in the area of medical science.
I'd like to return for a moment to the Equality Act. I think one of the concerns of many of the physicians that have tuned in today is that what is their recourse if they resist gender-affirming approach to the treatment of their patients? Is there any recourse? Many of them are concerned about being dismissed, being canceled. What are your thoughts about how to respond thoughtfully in a Christian manner, as well as a medically acceptable professional manner, to the threat that many of them are feeling?
So I would say that each physician has their area of expertise, their domain that they participate in medical care. I think it's critically important that we reach out and accept this patient population and provide quality medical care in all aspects, of their needs, which is not limited to the gender affirmation that many of them are seeking. They all need regular, well patient visits, immunizations, screening for cancers, education on lifestyle benefits. There are many things that physicians can do, and really approaching them, acknowledging their human dignity. We show this inherently as physicians, that we care for them. Most of the people that I interact with in other areas, there can be clear differences in desires as far as what they're seeking. I have patients that come to me for other conditions that desire a particular intervention, and I have conversations with them as to why I think that is or is not a prudent approach. explaining risks and benefits. And again, why this is being carved out in this particular area because of all of the the political arena that we're dealing with isn't necessary. We can certainly apply the way we practice medicine in other areas. And I think all of the physicians that are encountering those challenges can look to dozens of other areas where second opinions are sought because the patient doesn't like what you recommend for them, and really being able to maintain that as far as the advice. And so, as far as cooperation, in something that we see as harmful, we need to be very careful about what we recommend, but always at the heart of what we do is in the best interest of the patient. And so that, again, we need to apply that medical principle. So when you say that this is not an intervention that I can recommend, these are the reasons why, based upon this evidence, I think is a better approach than to say, that I have a blanket decision that I'm not even going to consider this. So again, within our areas of expertise, many of the practitioners, very few of them are endocrinologists, very few of them are surgeons that are being asked to provide this care. Even in the world where you have a subspecialty, we have people with greater expertise in one area versus another, and referring them, for proper care. The challenge is finding the right person that is going to be able to have considered all of the things that I spoke about this morning and more. We only touched upon a very small fraction of the information that's available. So that's a general instruction, and I hope that that's helpful for those that are confronted with this. It is an area of concern, but I think we should always hold firm to our medical principles, the Hippocratic Oath that most of us said when we became physicians, and how we apply that, and really focus on that rather than on the specifics that we're perceiving that we're needing to go through.
Has there been any effort to create a cohort of colleagues in various specialties that share common concern to allow science and what's been considered best practices all around to maintain a dialogue and to be a source of encouragement to one another?
Well, thank you for the question. And I want to actually point out that there are groups that already exist. And in this particular area, even within the area of transgender medicine, the Society for Evidence-Based Gender Medicine, SEGM, is a resource where people are looking at it precisely from that perspective, to be able to look at this objectively, to look at the science with the goal of using evidence-based medicine, to be able to review the literature, to be able to summarize that data, and to be able to provide that information. So there are groups that already exist, and we don't need to necessarily invent them, to do that. I think the information that's already present on the CMDA website has very, very helpful information. This is a means, to dialogue. But I think that there are people that, from all different worldviews, and it's not, because this is a scientific and best practice of medicine question, that when one looks at that from that perspective, there's tremendous benefit. So again, that's what I can offer as help to you.
Have you seen any connection between the explosion of gender dysphoria among adolescent girls and eating disorders?
I didn't mention that directly, but that is a very well-known association. And so even the people that are participating in gender clinics recognize this. There's many papers that are published with this. The question then, comes to how is this similar or dissimilar to other eating disorders? And the connection that many people have drawn is that of anorexia nervosa. It's often bulimia as well. We know that especially the adolescent females that present with gender dysphoria, a proportionate number of them that are experiencing obesity and related to some of that. It's very interesting. Again, there are different conditions, but there's some underlying principles that one can apply. So for example, the condition of anorexia nervosa, there's a disconnect between the objective reality of one's body mass index or BMI and their perception about whether they're overweight or not. Now, it's a different condition, but one can ask the questions about how they may be related. So that association is known. It's well recognized in this population. There's many papers that one can find showing this association, and there is efforts to address that that in the treatment of these individuals. How much one again in the gender clinics that are offering this care. Many times, for example, people are coming for the hormones, and because of the obesity and metabolic syndrome, have contraindications that are beyond the ones that I mentioned in my talk here, as far as dyslipidemia, where there's caution in being able to deliver these hormones. So I appreciate the question, and the answer is absolutely yes, that there is a link and an association that's well known in this population on eating disorders.
Do you have any idea of the number of children in the U.S. that are engaged in puberty blocker hormone therapy?
So the data that's out there, again, taking it at face value for the quality of the data. So every time you ask the question and generate, the data, there's each center will keep track of how many patients are being present. I showed the Tavistock data because all of the patients go to a single center. When they're scattered out throughout the 50 plus centers in the United States, gathering that information can be challenging. Getting the information solely from things such as there's data available in the US Transgender Survey, which predominantly looked at adults. And even that data itself has an inherent bias, because those that answered the survey may or may not reflect the population that did not answer the survey. So answering the question is not clear. So when I mentioned earlier, there was a couple of studies that came out with, for example, one in Minnesota, which said about 2.5% to 3% of the of the pediatric population questioned their gender identity. That's not to say that entire segment is all approaching gender centers or engaging in hormone therapy. It's also not to say that everybody that presents themselves to a gender clinic is going to receive the full spectrum of gender affirming care. But what we're seeing is that by the time that they reach that point that they're presenting to a gender center, the majority of them will be offered puberty blockers, and then trying to look at that percentage of people that are offered those puberty blockers and that go on to get the cross-sex hormones is relatively high. A much smaller percentage that are going to go on to get the surgical interventions. So it's a limitation of the data we have, but it's a growing number of people. If you look at the number of the centers that are being developed and the patients that are being seen at those centers, it is a rising population in the US, just as it is in the UK data that I showed.
Have there been any lawsuits that have been filed that you're aware of over the issue of affirmative therapy?
There are certain, so this type of litigation is in its early stages right now. And again, part of this relates to the length of time that this is being offered to children, and many other factors. Most of the litigation in the pediatric world has been centered on whether one should be allowed to do reparative therapy. It's often presented as conversion therapy, and incorrectly conflating that with treatments done several decades prior in the area of same-sex attraction versus even as far as laws are concerned, as far as lawsuits in the area of bathroom use, and the accommodations that people need to make. So the field itself is developing right now, and again, it's more related to the novelty of what's going on and the length of time it takes things to work their way through the court system. So that's about the extent of what I can say as a pediatric endocrinologist, not as a lawyer.
Do you see an occasion coming when parents or even physicians may be accused of child abuse if they do not respond to what's being considered the appropriate narrative at this time of affirmative therapy?
It's actually beyond theoretical. It's actually an actuality that's already occurred. There have been children that have been removed from the custody of their parents because the parents objected to the gender affirmation approach that was done. So this is something that has already occurred, and it's certainly something that everybody should be aware of. And as time goes on, to the extent that that's going to be put forward, parents are put in a very, very difficult place in all of this, and we didn't talk much about that. They're coming to medical professionals seeking help for their child who is suffering. Many parents have differing viewpoints about what should or can be done for their child. Many of them are just seeking help, and they inherently, as a parent, have reservations about the affirmative approach, yet they're being told by the medical profession that this is the only approach that they can pursue, and not having the medical background, not having the standing, to challenge that, they're putting in a very difficult position. There are many physicians themselves that don't have the depth of understanding of this area, as we talked about this morning, all the more so for parents. And so it really is something that we need to acknowledge. Parents inherently want to do what's best for their children, and many times, they know that things that their children wish to do are not going to be helpful for them. And there's reasons why we don't allow children to drink alcohol and smoke before they reach a certain age. And in this area as well is parental working in the best interest of their child. It's because of what's been put forward. So we're already at the stage where that is being done.
Thank you, Dr. Roos. This has been a fascinating morning, and we appreciate so much the contribution that you've made to the whole issue of clinical perspectives on the transgender movement. We look forward, Father, to further discussions with you in the months and years ahead as we follow this trend in our culture. We certainly thank you for taking your time and for being bold enough to articulate, even among the colleagues who may disagree with you, your position on this issue. We've appreciated so much your being with us today. For those of you who have participated in today's presentation, we want to thank you for registering. And we just want to let you know that we will be making the recording available to you in the days ahead, and we'll provide that location for you. On behalf of the Christian Medical and Dental Associations, and may I say on behalf of Dr. Roos, we want to thank you for participating with us today. Goodbye and have a great day.